Good afternoon, everyone. Hope we are all doing well today. Welcome to what promises to be an informative and important discussion on COVID-19 vaccines. We have with us Professor K. Srinath Reddy, President of Public Health Foundation of India. And before I introduce our guest today, I think he doesn't need much of an introduction, but let me quickly also recap Patients Engage. For those of you who are not aware, we are a digital platform operational for over 5 years and focused on evidence-based and holistic management of chronic conditions from perspective of patients and caregivers. We believe in the value of lived experiences and strongly urge each and every person to be better informed and proactive about managing health and chronic conditions in order to improve your quality of life. Our series of webinars allow you to interact with healthcare professionals as well as persons with lived experiences. Today we have with us Dr. K. Srinath Reddy, or Professor Reddy as he prefers to be called. He has a long list of achievements, but I'll just quickly pick on a few. He is President of the Public Health Foundation of India. He was formerly Head of Department of Cardiology at AIIMS. Under his leadership, PHFI has established 5 Indian Institutes of Public Health in various regions of India. And the objective is to advance multidisciplinary public health education, research, health technologies, and implementation support for strengthening health systems. He was appointed a first Bernard Loan Visiting Professor of Cardiovascular Health at Harvard School of Public Health and serves as Adjunct Professor of Epidemiology at Harvard. He holds various advisory positions, several national and international bodies, and he's recently published a book, Make Health in India, Reaching a Billion Plus. He's also an adjunct professor of the Rollins School of Public Health, Emory University, and honorary professor of medicine at the University of Sydney. He's the first Indian to be elected to the National Academy of Medicine, USA, and was awarded several prestigious international and national doctorates and fellowships. Also president of World Heart Federation. He is a Padma Bhushan awardee, advisor to the governments of Orissa, Punjab, Haryana, Andhra Pradesh on public health, member of several of the state and center COVID-19 and public health task forces. He's also on the, let me move this around. He's a member of the WHO Executive Group of International Steering Committee for COVID-19 Solidarity Trial and member of the Lancet Global Commission on COVID-19. So I think that's, there's a lot, and we know that we have significant expertise here. So let's get started. A quick reminder to everybody, as always, this is our standard disclaimer. This does not replace a medical consultation. So you do need to discuss and contact your doctor for specific medical issues. This session is being recorded. If you're logged into Zoom, please post your questions on the Q&A. If you're on Facebook, you can post them on the live feed and we'll pick them up from there. We'll try and address as many of them as possible. As always, you can follow any of our social media handles. Our website is patientsengage.com, and you can write to us at editor@patientsengage.com. So let me get started right away. Doctor, as you, I think, said also in a recent article, safety, efficacy, and the duration of impact are important principles for vaccines. In light of the fact that this vaccine, the COVID-19 vaccines have been developed at what is called warp speed, what are the implications in terms of safety?
I think firstly, we'll have to look at what the nature of the scientific enterprise has been as an organized effort. And secondly, we have to look at the regulatory diligence. I think in terms of scientific methodology, we have seen tremendous progress over the last 20 years and even in the last decade.
Right.
We have seen, for example, new vaccine platforms like the mRNA platform coming in. We have seen within 10 to 11 days, the genetic structure of the virus being put on the net by the Chinese government. And that enabled almost every other nation to really attempt to identify the virus or even try and develop some vaccines for it.
Right.
And also we recognize, even in terms of the trials, some methodologies have been adopted which are relatively novel in terms of trying to collapse phase 1 and phase 2 trials, and sometimes even start phase 3 trials while phase 2 trials are on. That is because of the nature of the global pandemic.
Right.
But we also know that the number of volunteers who lined up for the trials was also quite huge, because the pandemic really created a panic, and also it created a huge economic slowdown.
Right.
So people wanted that we needed a vaccine to come in order to find a solution for this soon. And therefore, the scientific enterprise was speeded up at the level of science. At the same time, even people were willing to participate in large numbers. And given the rate of infectivity across the world, the volunteers were coming in from different countries and different age groups.
Right.
And even in drug trials, you found a large number of people coming in. So I think from the point of view of science, it was not really a hurried effort. It was a speeded up effort in that sense. But having said that, ultimately the test lies in a completed phase 3 trial. And all the data which are available at that time of both efficacy and safety have to be scrutinized carefully by the regulator.
Right.
And apart from the regulator, ideally it should be out in the scientific domain, in scientific journals for peer review, and also for the rest of the scientific community to satisfy itself that the data actually stand up as a true testament to efficacy and safety. And then, of course, the media and the public, representatives of the public, also have a right to know what the data are.
Right.
And how valid the assertions are. So I think those are some of the issues that we need to consider. I believe in terms of completion of the phase 3 trials and submission of data, it has been done, at least in the case of one vaccine, and others are lining up to do that. But in terms of how far the regulators have really applied their mind, we'll have to wait and see. But it's absolutely important that this comes out in the mainstream scientific journals as well as in the wider public view. But as you know, in the Pfizer biontech regulatory process in the United States, there were open public hearings before a whole scientific community, and even representatives of the public could tune into those hearings.
Right.
So it is that kind of transparency that we really require before a regulatory approval comes in.
Okay, thank you. So the questions that are coming up are, will the vaccine have, or will any of these or all of these vaccines have side effects? And do we know the side effects that we should expect?
Well, most vaccines will have some side effects. As long as they're minor and mild and are likely to be very temporary, we should be accepting it, because the protection that is conferred is worth the effort. I mean, for example, a little pain at the injection site or swelling at the injection site, maybe even fever for a day or two. That is something that often happens with several vaccines, including the flu vaccines.
Correct.
But if there are other adverse effects, and we know some of the other vaccines in the past have had adverse effects, particularly with live vaccines, which actually caused illness. And we also know that some vaccines have something called antibody-dependent enhancement, where they actually paradoxically create an open channel within the cell for the disease.
Sorry, I think we have lost Dr. Reddy just a little bit. He's frozen a little. Hopefully he will be back soon. So for all of you watching, I think Dr. Reddy seems to have, his screen seems to have frozen, which is why we're waiting for him to probably join back. Yeah, Doctor, you're back. You're on mute, yeah.
So basically, we'll have to see whether we actually, these effects are, whatever have been observed, are causal or coincidental. Are they something that happen in general anyway, nothing to do with the vaccine? What is their proportion in comparison to their occurrence in the general population? And then what is their proportion in comparison to the people who have been given a placebo injection in the trial itself?
Right.
And is it purely coincidental, or does it appear to be causal? So those are the things that need to be looked at. So bottom line is, minor side effects will be there. They're acceptable. Major side effects will have to be watched out for. And certainly if there are many, then it's not acceptable. And that's where the regulator comes in during the trial. But even post the trial, we have to keep a watch out for them.
Correct, correct. So for a lay person, is there a difference between that they should know? Because, you know, this pandemic has been kind of strange, right? That all of the science and discussions, etc., are in public news. So people are trying to grapple with what they need to know, etc. So do they need to understand what's the difference between a side effect and an adverse effect?
Well, basically, a minor side effect is you can have a bit of a minor illness or an ailment, and that, which could be just caused by the injection.
Right.
It need not be, even if you get a B complex injection, you can have a swelling and pain. Whereas an adverse event is specifically related to the vaccine itself.
Right.
It's caused by the vaccine itself. So that is what you're really looking for.
Okay. And the adverse effects could even be delayed, right? They may not be. So the pain, the side effect of the injection is immediate pretty much. Whereas adverse effects could be delayed, or are they typically likely to be immediate?
Well, they can be immediate effects, but we know that they can be delayed, and that's why you need to keep a 6 to 8 week window after the injection in almost every person who has received the injection to observe.
Right.
But we know that it may not sometimes be seen during the course of the trial because some categories of people might not have been included.
Right.
Like in the Pfizer biontech, people with allergic disorders were not included in the trial. But when they started rolling out, 2 of the people in the health workforce, health workers who had allergic disorders, and fairly severe ones at that, prior to that, then they suffered what's called an anaphylactoid reaction. They didn't go into shock, but they had other features.
Right.
So that came out when it started getting into the general population. And that is why you definitely need, even after the trial is completed, to keep track of whoever is getting the vaccine and then trace whether there are any side effects. And since the numbers are now going to be very large, some of the relatively rare side effects will actually manifest themselves much more in the post-licensure follow-up phase.
Right, right. And in terms of, so for instance, if you look at India, will people have an option to choose a vaccine because there are multiple vaccine makers at the moment? So will there be a choice, do you think? Or, you know, because I know some countries are saying we'll start with one vaccine and as the others come, we'll evaluate whether to also roll them out. Do you have a view on that as to what that would mean?
Well, there are several candidates who are actually right now in the race, but there are 4 platforms which are relatively more advanced, and within each platform, there are 1 or 2 or more vaccines. So among those vaccines which are now fairly close to moving to the regulator or already have approached the regulator with their phase 3 trial data, we will have to wait and see. We know that the first 2 which have lined up are the 2 mRNA vaccines, the Pfizer biontech and the Moderna. The Moderna still hasn't received its approval. The Pfizer biontech has in the UK, US, and Europe, and now it's being taken up elsewhere too. But it's likely that given the large number of vaccines that have been developed and the many more that are actually being put in the preclinical phase now and are likely to enter the clinical phase, if you combine both of them, there are about 200 vaccines plus, about 48 vaccines which are in some form of clinical trial, some phase of clinical trial, and about 160 plus which are in the preclinical developmental phase. So given that, we expect there will be more than one successful candidate. There could be 3, 4. And given that there are 6 platforms, different platforms for developing these vaccines, we expect we'll have a choice even of the platforms. So if some are going to be very difficult in terms of their cold chain requirements, we may actually get others which do not have that kind of a stringent cold chain requirement. Some which can even be stored at room temperature.
Right. And in terms of, some of these vaccines are 2-dose. In fact, most of them, I think, are 2-dose vaccines, right?
There's only one which is 1-dose vaccine that's still under trial.
Right. So in these cases which are 2-dose, is there a requirement for quarantine, isolation between the 2 doses? Or, do we know that as to also when you get infected or not infected, when you are given a vaccination, are you more likely to infect others? Are you more likely to get infected? Do we know those things?
No, because look, before the vaccination, you're going around, of course, with physical distancing and a mask.
Right.
There is no reason why it should be different after you've got a shot. Particularly if it is a mRNA vaccine or if it is a inactive vaccine. It's only in the case of a live attenuated vaccine where you may not be sure whether that is multiplying in the body, which is unlikely also. So therefore, between the 2 shots or after getting the second shot too, the question is whether you are sufficiently protected or not. Because it takes a while for the immunity to develop.
Right.
Even after the second shot, it takes about 2 weeks for the immunity to really develop. So you still are vulnerable. But it's not that you pose a threat to others because you have been vaccinated. No, you don't have to quarantine yourself.
Okay, all right. In the past, right, while we had the flu vaccine, it was largely optional. And people made the decision as to, I am not at high risk and therefore I don't need a flu vaccine, or it was not like a polio vaccine, which was pretty much mandatory, right? So where do you see this vaccine fall? Is it like the flu vaccine where individuals will be allowed to make the decision? And if so, should they look at it differently from the flu vaccine?
Well, basically, I think in any immunization program, it has to be voluntary. You can't force anybody to have a vaccine. Though we must try and convince people that it is for larger societal good.
Right.
Because if a person resists immunization and acquires the virus, he or she is not only hurting herself or himself, but also the family, the neighbors, co-workers, and any other strangers they may encounter in the market or in the transport.
Right.
So in a sense, you are posing a threat to others if you get infected. Therefore, it is important that as a societal responsibility, we do not really expose others. But having said that, ultimately, individuals should be persuaded to have it, never coerced to have it.
Okay. But also in the 2-dose, there is also the challenge, right? How do we make sure that people who've had the first dose also do have the second dose? So do you expect that to be a little bit of an implementation challenge, especially if there are some minor side effects after the first one?
No, it's a matter of logistics, but it's a question of sufficiently impressing upon people with adequate information, preparing their mind. If they're prepared for minor side effects to manifest even after the first injection, well, even after the first injection, if everything goes very smoothly, they'll be happy.
Right.
But if there are those side effects, then they will understand that it has happened. And they'll be coming back next week because they've already made that investment in their mind that they want that protection.
Right.
But if we do not explain, it catches them by surprise. We do not reassure them, and we do not give them sufficient care during the follow-up period, then they're likely to be reluctant to come back for the second injection.
Right.
So it's partly technology in terms of tracing people, but much more than that, it is the soft skills of communication.
Right, right. Yeah. I guess let me take some of the questions that have started coming in. It's question on patients who have immuno. So have the trials included chronic patients, and especially those who are on immunosuppressants, steroids, etc.? And, is it suggested that they also take vaccines?
See, the problem is people who are either immunocompromised for whatever reason, because of the underlying illness, or immunosuppressed because of the treatments they are receiving, they are generally not included in these trials. So from that point of view, if you only look at the trial data, we will not be able to say, okay, these people are, okay to have or not okay to have these vaccines. Therefore, we'll have to go by some other biological considerations in terms of whether we want to give it or not. Now, there are certain type of vaccines you don't want to give.
Right.
Particularly, you don't want to give even live attenuated vaccines, because in an immunocompromised person, that live attenuated vaccine could be problematic.
Right.
That could actually turn to be virulent. Even the virus vector vaccines, like the AstraZeneca, which we are looking as possibly our first candidate in India, that is a virus vector candidate with an adenovirus, which is generally considered harmless.
Right.
But in an immunocompromised person, that can actually become harmful. So we don't want to give that vaccine either. On the other hand, a completely inactivated virus, like the Bharat biotech vaccine,
right.
if that becomes available, if that passes the regulatory test, then that's fine.
Right.
Other completely inactivated vaccines available. The 2 Chinese vaccines are completely inactivated. Whether the government of India decides to get them or not, whether individual patients can import them or not, I do not know. So at the moment, I think it is best that we provide protection otherwise and wait for the Bharat biotech vaccine to prove its efficacy and safety.
Right.
But having said that,
right.
if somebody is exposed to a virus and is immunocompromised or immunosuppressed, and we are worried about the danger of their developing a severe COVID infection, the monoclonal and the polyclonal antibodies, which are now being synthesized, they can actually help in providing the immunity. It's a passive immunity, unlike a virus vaccine, which provides active immunity.
Right.
So there are methods even before the other vaccines are available to provide protection to them. It's going to be a bit expensive, but that may have to be the way to go for such people.
Okay. What will be what will be the period of protection, especially because there is news of new strains coming up?
Well, we do not know, frankly. If you look at the antibodies, most of them have disappeared in about 3 months, but that is for the natural infection. It's possible that with the 2-dose vaccine, there will be a stronger antibody response.
Right.
Secondly, the T cell or the cellular immunity component seems to be lasting at least up to 6 months. This is a relatively new virus, and we are still tracking both the people who are naturally infected and people who have been vaccinated.
Right.
So we still do not have that length of follow-up to say, okay, it's going to last 9 months or 10 months. But it does appear that cellular immunity will last up to 6 months. And as opposed to the natural infection, where the amount of virus load is very variable. It could be a small load, it could be a high load, and therefore the immune response could be variable too. In a vaccination program, you actually give a relatively standardized dose, which is likely to evoke a much stronger immune response. So going by the general rules of coronaviruses and pitching this virus somewhere midway between SARS-1, which gave a 2-year immunity, and the common cold viruses, which give you about 3 to 6 month immunity, this is likely to have anywhere between 6 months to 1 year immunity.
Okay.
And we'll have to wait and see.
Yeah. And do you know if they've been tested on COVID survivors?
Well, they've not been tested on COVID survivors, but it makes logical sense to have a COVID survivor take it, for the very reason I said. A natural infection doesn't give you a predictable dose of virus exposure.
Right.
So your immune response also can be very variable in terms of its strength and duration. Therefore, if you have a vaccine with a predetermined strength and given in double dose, the likelihood of a stronger and longer immune response is there. Therefore, even for a COVID survivor, to take the vaccine appears to be the rational choice. They may not be the first in line, but it's better that they do.
Okay. And that, I think, answers the question somebody asked: should healthy people at all consider being vaccinated, as they can continue to protect themselves with mask distancing and frequent hand washing?
Yes, I mean, it may work for them, but then you are likely to get more assured protection. Now that we are seeing the results of these vaccines, which are promising very high level of efficacy, you're likely to get much more assured protection. And now I'm not saying that this is the right thing to do, but looking at newspapers, you can find out that airlines are saying that you must either produce a virus negative test certificate, or preferably after the vaccines come in, you must actually produce a vaccination certificate.
Correct.
So in a sense that even if you don't feel the need to get immunized, others may want you to prove that you're immune.
Yes. mRNA vaccines may cause genetic modification. Is that true? And also, does it cause severe infection after vaccination?
Unlikely that the mRNA vaccine causes any genetic modification. mRNA is made by the cell, particularly derived from the DNA. It's a postman. It carries the message to the ribosomes to produce certain types of proteins. And it gives the instructions and period, that's it. It doesn't track back to the DNA. Therefore, to get integrated into the DNA and cause genetic modification is extremely unlikely.
Right.
The DNA vaccine, on the other hand, and there is one that is actually being made, and even in India and abroad, that could be a problem in terms of genetic modification. We do not know. But this is uncharted territory. But purely on theoretical considerations, it appears that the mRNA vaccines are unlikely to cause any genetic modification.
Right. And there is, because there's been some announcements, right, of 300 million or 260 million or something as the number of vaccine doses that will be procured and dispensed in India. I guess the question is, what percentage of population should be vaccinated in order to end the pandemic situation?
Well, we do not know for sure. See, the problem is, as far as the infectivity is concerned, we do not even have clear proof from the trials. What the trials are trying to show is that if a person is exposed to a virus, will the person develop significant clinical infection, mild or moderate or severe?
Right.
But it doesn't necessarily prevent you from getting infected in the sense, in a technical way. If the virus enters your nose or throat and stays there for 2 days without causing any problem, without causing illness, without causing disease, then in a sense you're infected but not ill. right?
Right.
So therefore, it is not sure at this point in time what we really can say about the level of protection that the virus, that the vaccine can give. And therefore, what we are really trying to do in the initial stage is to protect the people who are most seriously vulnerable and those who are essential. So you take the essentiality criterion, health workers, other essential workers will have to be protected, because if they fall ill, then they are likely to, many services will collapse.
Right.
Whether it is health services or transport services or security services.
Right.
So you don't want those services to collapse. Secondly, health workers are more frequently exposed to high viral loads and repetitively exposed to many patients with high viral loads. So they can fall ill too. But the vulnerability criteria is also there for elderly people and other people with other disease conditions, what we call comorbidities. And there the disease can be very severe. And since the primary purpose of the vaccine is to prevent significant disease, severe disease, to protect lives, they will get a priority. Now, whether we will be able to interrupt the chain of transmission in the entire society only through the vaccination, we do not know what the threshold will be. It may be 50%, it may be 60%, we do not know. But the first aim is to reduce the probability of severe illness and death among the vulnerable. Second is to reduce or slow down the rate of transmission. Because even if you get vaccinated and the virus does come and stay in your throat or nose for a couple of days, if you're not ill, you're not coughing, you're not sneezing, you're not throwing out the virus in large numbers to other people. So the transmission also will be reduced.
Right.
But we cannot say that 30% or 40% or 50% is the level at which this is going to stop.
Right.
The more the people take it, the better it is.
And do we know if the vaccines has any adverse effect on people with comorbidities, like especially diabetes and hypertension, which is very high numbers?
Unlikely, because while they may not have specifically looked for that in the inclusion criteria, some of the vaccine trials have included older people. Some have gone up to 65, some have gone up even higher. And many of them would have comorbidities.
Right.
See, unless you have to do a much larger trial with these predefined subsets, and then only you will be able to see whether there is a specific effect. But the fact that many of the older people actually have been protected in these trials suggests that people with comorbidities actually may stand to benefit rather than come to harm.
Okay. There's a question on children. As far as I remember reading, they're now going to do some trials on children, right?
Yes.
If you want to elaborate.
18.
Right.
Previously, they had stopped at 18, and that's why there was a lot of debate when they tried to include the 16 to 18 group also into the indications, whether others said, how come these people were not included in the trial? But now they're planning to do trials from 12 and above.
Right, right.
But children generally are at a much lower risk of severe infection. As I keep repeating, the main purpose of the vaccine is to prevent illness, not so much to prevent the infection.
Right.
A virus may still enter your nose and stay there for a couple of days, cooling itself.
Right.
But it will not be able to make you ill if you are being vaccinated. And children generally do not have the risk of getting severe illness. So that's why they are not the highest priority.
Right. Question, is this vaccine safe during pregnancy?
Well, pregnant women have not been included in the trials. And generally that is a standard practice for most vaccine trials. And right now there is actually a plea that is being made by a number of organizations that should not deter people from giving the vaccine to pregnant women, because they are also at considerable risk. Now that's a policy decision that has to be made on weighing the theoretical considerations and seeing whether they're more likely to be harmed or more likely to be benefited. But if you're looking for evidence from the trials that have already been conducted, we don't have that evidence.
Right, right. Somebody's asking, we have a lot of vaccines for bacterial infection. Why can't existing vaccines be utilized? since the symptoms are similar?
No, this is a virus infection. Each microbe requires its own defense mechanism. I mean, if we had vaccines that worked against different diseases, the same vaccine could work, we would not be in so much trouble.
Right.
I mean, each different vaccine, each different virus and each different bacterium has its own characteristics, and you have to attack those characteristics. Very few of them will share the same proteins. And most of these vaccines are directed against the proteins. Now,
Right.
I mean, they have their own proclivities and individual characteristics.
One question on, should industries plan vaccination within their factory premises?
Well, it's possible if employers wish to do it, that they feel it's partly their responsibility and partly it's also safe to have their workers protected and productive without falling ill. They can undertake it, but where are they going to get the vaccines from? Are they going to import them, or is the government going to permit a special quota for employers? And secondly, who is going to come and administer them? Are they going to hire people from private sector, healthcare sector, doctors to come in and then give it, or nurses to come and give it? So that is an organized effort, but it is understandable that employers may want to do that. So they should actually connect with the government to work out modalities for that.
Right. And has the sequence of, I know everybody says the first phase is healthcare workers, essential workers, security, etc. Are the subsequent phases defined as yet or not yet?
Well, obviously the initial supply chain is not going to be very wide because the mRNA vaccines are going to be quite daunting in terms of their cold chain requirements, especially the Pfizer biontech. You may be able to give it for a few people in the large cities where the facilities are there.
Right.
Maybe some prioritized groups might get it. mRNA is a little more easy to handle because it's -20 rather than -70.
Yeah.
But even that for this large country is going to be too much of a logistic challenge for us to handle. By the way, cost is also a problem at the moment, and availability is going to be a problem. But the mRNA vaccines over a period of time will be among the cheapest to produce and the largest to produce in volume.
Okay.
So if India can develop these technologies themselves and can sort out the cold chain issue, at least for the -20 level, then it's possible that we may be able to do it as well. But as of now, the mRNA vaccines are really off our table.
Right.
And therefore, we have to look at other vaccines. And then if the supply chain initially is going to be somewhat constricted, then the highly prioritized groups will have to receive it.
Right.
And then as more vaccines become available and even the production volume increases, and even some of the vaccines that are developed outside may come to India for licensed manufacture, and vaccines developed in India may pass the test. So then the supply chain will increase and other groups will be covered.
Okay. One question on mRNA. Considering it is an mRNA vaccine, is it not going to suppress the immunity of an individual?
No, because the mRNA is essentially a messenger asking the cell to make a particular protein. In this case, it's mostly asking the cell to make the protein again, create the part of the spike protein of the virus.
Right.
And once the spike protein is produced, then the body recognizes it as something foreign and then starts reacting against it with an immune reaction. So essentially, what the mRNA is doing is what your delivery man comes to give you a parcel at home, rings your bell and says, okay, go ahead and this is your supply. And then the ribosomes, which actually make the proteins, then start making the protein, and then the whole body starts reacting to that new protein. Therefore, mRNA doesn't have any other impact in that sense.
Right. And do we have any idea as to when we expect the vaccinations to start in India?
Well, we do not know because right now AstraZeneca is the one that is most poised, but that has to first get the regulatory approval of the British regulator because that is where the largest trial, part of the trial has been done.
Right.
Though it's a multi-country trial, that is where it's been mostly done, and that's where they actually have approached the regulator for the first permission. So even the Indian regulator would want to see what the British regulator has seen, the data there, plus be reassured by the fact that the British regulator has applied the mind and has scrutinized the data and has given the permission after due diligence. Then only the Indian regulator will give the green flag. So we do not know exactly when that's going to happen, but probably that will be the first in line. And then others which are made in India or even developed in India will line up after that.
Okay. I think we are getting to the end of our thing. Just want to ask a few questions. I know that some countries are saying that the whole process of vaccinations will take 2 years, 3 years. What is the expected timeline, and how do we see us? Will we continue to have to stay masked and safe distanced for the next 2-3 years or the foreseeable future?
Well, I think we have to accept the fact that our victory against this virus in terms of ending the pandemic is going to come in stages. It's not going to come overnight. So, and whether it is going to come through the vaccination itself, whether it's going to come because a large number of people get immune, the so-called herd immunity, which is anyway not going to be coming in next 2 years, I can assure you that by itself. But also because the virus itself may change its character. Sometimes viruses do, particularly if we create a pressure for it and do not allow it to transmit easily, then it may mutate to a different form, which can be either more infectious and less virulent, or even less infectious and less virulent. We'll have to see. So those possibilities exist. But as of now, we'll have to possibly think that it will probably take at least a year for the whole world to be able to reach some new level of equilibrium with respect to this virus. But by the way, when you asked me about the immunocompromised, I did mention the inactivated viruses, inactivated vaccines as being relatively safe on theoretical considerations. Even the mRNA vaccines can be safe too for immunocompromised people. What will be not safe are the DNA vaccines, and what will not be safe particularly are the live attenuated virus vaccines.
And I guess that includes people who've just had an organ transplant as well?
Yes, because they are on immunosuppressants. So for such people, the best thing is to give, if we have access, to give them monoclonal or polyclonal antibodies, which will give them protection if they've been exposed to the virus.
And what do you, I think there are a few more questions, but I am very conscious that we have taken up a lot of your time. If you have 10 more minutes, we can continue. Otherwise, we will.
No, please go ahead.
Okay. So then let me continue. I guess there's a question on should we wait for inactive vaccines for old comorbid patients? I guess is what you kind of also said, but people are asking, should we actually actively wait?
If we get an inactive vaccine, let us say the biotech vaccine proves itself as reasonably efficacious and safe in order to warrant approval, then that would be the easiest for us for treating or protecting these immunocompromised people. If that is long in coming or for some reason there is a problem, then you may have to get the Chinese vaccines. Or you use the mRNA vaccines. Get them in limited quantities for this special category of people. Because then you can meet the cold chain requirements in some of the big centers and do it. But if any of these people have been exposed to a person with COVID infection, and we are worried that this person is at risk, then if you have access to monoclonal or polyclonal antibodies, then that gives immediate protection.
Question, as an epidemiologist, what is the probability that a virus like COVID-19 will recur again in near future?
Unfortunately, I have to give a bad prediction. Because if you look at the last 60 years, about 2/3 or more of all the new outbreaks, infectious disease outbreaks, have been animal to human transmission,
Right.
zoonotic. That's not because animals have suddenly become malevolent towards human beings. It is because we have created conveyor belts for viruses which were happily residing in forest animals to come and enter our captive bred animal populations, which we are using for human food, or because of deforestation, because of a variety of reasons like urban expansion, mining, and animal breeding. We are allowing all those viruses and the vectors of other microbes to come into human habitat as well, and are creating these conveyor belts. And because we live in large numbers in crowded cities and we travel very far and fast, we tend to carry these viruses with us. These microbes will travel with us and they celebrate with us in crowds.
Right.
Because then we are giving them an easy passage. So we have to be much more careful about our ecological balance, the way our urbanization patterns are developing, before we say that we can actually prevent some of these zoonotic pandemics from occurring. Right. Secondly, we need to build what is called One Health surveillance. Tracking microbes from forest animals to veterinary population to human population, and getting the early alert systems when these microbes are beginning to appear in animals, either pets or captive bred animals, and then say, okay, very quickly, this could turn into a human epidemic.
Right.
And therefore, we need those early tracking systems of One Health surveillance. So, therefore, my plea is, yes, we are living with the danger of fresh pandemics occurring, but it is in our ability to control them. The behavior of the viruses and the microbes is conditioned by our behavior.
Right, right. Quick question. What is the protocol for patient consent prior to administration of a vaccine?
Well, I'm sure the person, the protocols would have been developed by the government and the agencies who are looking at it. But usually the process of immunization is explained. The reason for immunization is explained. What actually happens during the injection process is explained. The potential for minor and major side effects is explained. And the precautions to be taken after they've gone, and the process for reporting any side effects even after they've gone home, all of that is explained. And who to contact will be explained. So that will be the general protocol when a consent is taken. I mean, it won't be just a grab and jab process.
Right. In terms of communication, I think coming back to that, one of the challenges of this pandemic was that initially we said, for instance, masks are not necessary till we had to change that guideline. Do you anticipate, I mean, one of the issues that is happening is everybody sees vaccine as a savior, right? But we know that it will take, even if we were to deploy, it will take probably 2 to 3 years, maybe even more. What is the kind of communication that needs to really go out, and what's the best way of addressing that?
Well, I think we do need constant and correct communication all the time. That conversation with people needs to go on, not just through mass media. Mass media are very important, but it also needs to go through community networks, because ultimately the pockets of resistance form there and can be broken there.
Right.
And that is where I believe it's important for us to keep talking about it, not to frighten people, but to say these are the ways for protecting oneself. These are the ways for protecting our family members and the ones we care for most. And since this is likely to be a bit of a long haul, we do need to take these precautions and again avoid large crowds apart from personal protection measures. And things like try and get as much sunlight as possible and as little of pollution as possible. Keep your houses as ventilated as possible. Offices and schools as ventilated as possible. So these messages will have to keep on going. And
Right.
ultimately, it will be the collective will to overcome the virus that will succeed. So I think keeping the community constantly engaged is absolutely important. And even as the virus vaccine is being rolled out, I mean, we have a tendency to see technology as the solution to everything. But then even for acceptance of technology, people will have to be mobilized and convinced and engaged.
Right.
And also, we must recognize that, okay, the vaccine may confer protection only for 6 months, for all we know. But can we actually reduce the transmission to the extent in those 6 months so that we can actually make sure that the virus has virtually gone underground? And what is the risk of it coming up again? And so we may have to extend our protective behavior even for another 6 months or another 6 months thereafter.
Right.
So whether it is till end of 2021 or even the beginning of 2022 that we have to be on guard, that is something that we have to think about.
Right.
But therefore, I would say the 3C formula: care, caution, and confidence. Care is your personal protection.
Right.
Masks, hand washing, and eye protection if you can. Caution, avoid large crowds.
Right.
Avoid ill-ventilated places. Confidence, yes, we can protect ourselves and protect others and continue to work, continue to study, continue to have some enjoyable social communion. So don't get depressed, because depression lowers your immunity.
Right. And I guess we need those 3 C's to counter the 2 F's, right? Fear and fatigue, which is what
Absolutely.
we are seeing now. So.
Absolutely.
Good. Thank you. Thank you, Professor Reddy. Thank you so much for taking the time to answer a lot of questions. I think we've had a record number of questions that we've received during this session, and you've really explained and answered it such that lay people also understand. So thank you again, once again, for your time. And thank you to the audience and participants for asking your questions and keeping us all focused on the topic at hand. And this is Aparna. Thank you.
Whenever patients say thank you, I say that we are doctors are in an unfortunate profession where we can't say you're welcome because we don't want them to fall ill again. But on a public health issue, you're more than welcome.
Thank you. Thank you.